well. I invite Dr. Professor
Thank you,
Kamaljeet
sir.
Singh.
Thank you so much. I find there are such young retinal colleagues sitting there who are very well trained. I was trained by myself, and I used to go during summers to RP Center because my sasural is there in Delhi. So I used to stay there in my sasural and used to learn lasers and angiography. There were no fellowships then. Dr. Lalit Verma, Professor H.K. Tiwari, Dinesh Talwar, Dr. S.P. Garg, they were the stalwarts, and whatever little I know of laser is because of these gentlemen. My teacher, Professor R.N. Mishra, was very much interested in having the newer equipment. Those days it was very difficult to get even a microscope, and even slit lamps were not available to the residents or even consultants. It used to lie in the head of the department's room, and nobody was allowed to check. Uska cover bhi nahi utarta tha kai baar. So at that time he could think of having fluorescein angiography and then lasers. It was really marvelous, and we initially अभिषेक 5 मिनट में बात 5 मिनट में बात करते हैं. तो initially we had a fundus camera. Zeiss fundus camera was there, which was given by the government of India to all the medical colleges, and it was lying almost waste in the medical college. Then when I became medical officer, he said that why don't you start doing this, and I was knowing nothing about angiography. So those days उसमें रील लगती थी, रील लगा के फिर नेगेटिव्स बनते थे. नेगेटिव्स में हम लोग उसमें जैसे स्क्रीन में एक्सरे देखते हैं वैसे देखते थे, और ये कंप्यूटर फ्रेंडली एंजियोग्राफी वाज नॉट देयर. So when I used to see them, the fundus examination was done by direct and indirect ophthalmoscope. Whatever the examinee used to tell कि ये है तो वही फाइनल हो जाता था. There were no photographs available. And first time when I presented photographs of fundus in a conference in Kanpur, they said that किसी किताब से चुराया है तुमने. They couldn't believe that you can take the fundus pictures in a medical college. So all photographs were from the. So Professor Anand Mishra, he said that you will start doing fundus camera, and gradually we in the year 1992 the first laser came. एंड उसमें भी जो लेज़र होता था, बेसिक्स इसलिए बता रहे हैं बिकॉज यू शुड नो द डेवलपमेंट. देयर वाज एक कूलिंग मशीन होती थी, पानी से वो आता था. उसके बाद वो जब आप लेज़र बर्न देते, जैसे पुराने ज़माने में एम्बेसडर कार होती थी, तो उसमें से जो जब आप स्टार्ट करते थे तो 10 किलोमीटर के बाद एक जूनियर आदमी बैठा होता था जो पानी डालता था उसमें, तब फिर आगे बढ़ती थी. तो उसी तरह का वो लेज़र था, बड़ा सा एक वाटर कूलेंट रखा हुआ था, और इधर ऐसा लगता था कि किसी मैकेनिक की शॉप में आ गए. और सिमिलरली जिनॉन आर्क, एज डॉक्टर श्रीकांत वाज सेइंग, इट वाज हाई इंटेंसिटी बर्न्स. 1000 माइक्रोन के करीब लग जाते थे, और इतनी ज़्यादा इंटेंसिटी होती थी कि रेटिना पूरी तरह से बर्न कर देता था. नॉट ओनली द रेटिनल पिगमेंट एपिथेलियम, वेयर दैट इज़ वेयर वी normally target when we do laser photocoagulation. So gradually we improved, and so I am thankful to these teachers. Laser, as I don't need to tell you all that it's the full form. We were not even knowing the full form then. So my basic questions used to be from MBBS and post graduates कि लेज़र का फुल फॉर्म तो बता दे यार. जैसे लेसिक आया, लेज़र आया, PRK आया, और इतने आ गए RK PRK सब कुछ आया वैसे ही. So it's light amplification by stimulated emission. What does this mean? This means that all the electrons, they keep on revolving around orbits. So when we put in a like argon laser की गैस है, जब लेज़र डालते हैं उस पर तो वो स्टिमुलेट होता है, and that it jumps into the next orbit. तो जब ऑर्बिट में जाता है तो उसमें एनर्जी पैदा होती है, and then what happens that this energy that liberates When it comes back, this electron comes back into the original orbit, then that energy is liberated and that energy goes as laser. So this laser can be transported from here to moon without any problem. All these white lights that we see, the visible spectrum that we see, this cannot go beyond miles. Whereas laser light, if you put here, it can go up to moon without any problem. It will not deviate. So there are certain qualities of laser photocoagulation, that it remains columnated, एक direction में जाते हैं, and they can travel to any distance. And we all know that these days lasers are being used in wars also. यहाँ से टारगेट करते हैं, दूसरे कंट्री में जाके मार के चले आते हैं. Similarly, we can hit the retinal pigment epithelium without any problem. You can cross the cornea, you can cross the lens without damaging them. You can hit the target and you can get the effect of the laser photocoagulation. So this was there. And how does it works? It works on the principle that it is absorbed by the pigments. Like melanin होगा तो वो उसमें absorb हो जाएगा, hemoglobin होगा तो उसमें absorb हो जाएगा, xanthophyll के जितने भी हैं. So all these pigments, retinal pigment epithelium में, because there is lot of melanin, so it usually goes there and it's there. जो xenon arc होता था, whereas it used to burn the whole retina and choroid, all layers were burned, so the damage was too much. So this is what we get, and the effect we will discuss later. So as I have told you that there can be gases, there can be crystals, and there can be liquids and diodes. तो पहले जो गैसेस आती थी वो थोड़े दिनों में वो मशीन ख़राब हो जाती थी, वो गैसेस का कुछ दिनों में निकलना बंद हो जाता था, और तब यूज टू बी वेरी एक्सपेंसिव फॉर अ इंडिविजुअल एंड इवन फॉर इंस्टीट्यूशन टू बाई अ लेज़र मशीन. So gradually when diode came, their life became longer, and now we can have, like I have a laser photocoagulation. In the year 1998 I bought this Iridix machine. It is still working. So उसमें अब छोटा सा कंसोल आ गया. हमारे यहाँ पहले वहाँ से लेके यहाँ तक एक कमरा था लेज़र मशीन के लिए. So that sort of situation has occurred now. And now depending on this, its usage is different. Like if you look at this spectrum, and the wavelength is starting from 400 to 700, this is the visible spectrum. So beyond this is called infrared, and below this wavelength is called ultraviolet, which you all know can be used for corneal purposes, and infrared is used for, like carbon dioxide and other lasers are used for removing the growths, carbon dioxide laser and all that. Our job is here we had blue-green wavelength laser, 488 and 514 wavelength के आते थे blue-green, और अलग-अलग situation में we used to use this laser photocoagulation differently in our patients. तो blue कहाँ use करना है, green कहाँ use करना है, ये seniors बता दें या आप पढ़ लीजिए, and then you used to. Green was considered the best for doing the laser in retinal photocoagulation. So then came the double frequency YAG laser, which is you all know 532 laser, which is being used these days quite regularly by all, and for retinal purposes mainly. And as it is mentioned that these are various wavelengths that are being used for laser photocoagulation. Rest of the indications that we have for laser photocoagulation, we all know. Commonly we get lots of cases of diabetic retinopathy where in a single day I used to do, in dozens of patients I used to get tired, and nobody used to enter into that room because वो जानते नहीं थे क्या लाइट वाइट हरी नीली पीली मारते रहते हैं और कितना गलत करते हैं कितना सही करते हैं, ये हमें भी नहीं मालूम था, उन्हें भी नहीं मालूम था. So that sort of situation was there then. And PRP वाले ही मरीज आते हैं ज़्यादातर, which means pan retinal photocoagulation. And grid होती थी, and प्रोफेसर ठाकुर साहब होते थे. तो वो जब हमें मिले तो उन्होंने नाम हमारा ग्रिड रख दिया था कि ग्रिड आया है. तो ग्रिड था which was macular photocoagulation, and then scatter photocoagulation, which means that a quadrant is affected, like in BRV we do scatter photocoagulation or scatter in when done in all the 4 quadrants, We call it pan-retinal photocoagulation. With 200 micron size, you have to give 1500 to 2000 burns. In a neovascular glaucoma patient, you need further laser photocoagulation. When you do laser photocoagulation, take care that you don't hit the vessels. Go into the retina where you can see the retina and don't touch the blood also. So you have to simply burn the retina with the laser photocoagulation and 200 micron shots in the central area, leaving this macular arcade that is there for PRP. For grid, then you decide depending on that. For grid, what you do is you simply give 1500 to 100 micron size, light white intensity burns, whereas in pan-retinal photocoagulation you give white intensity burns. Quite remarkable white intensity burns are given. And one space apart is the usual thing that is told. So these are some of the basics that I wanted to discuss. So diabetic retinopathy, BRVO, Eels disease has become less common these days. In our time, Eels disease was quite common, and we used to do lots of laser those days for Eels disease also. Then CRVO, then further glaucoma, and all those things have come for glaucoma. So these are some of the basic I wanted to discuss with you all, and then thank you so much.
Thank you, Dr. Kamaljeet, for giving a brief history about the evolution of the lasers. And then say one interesting point I want to mention, because now many semiconductor lasers are there. I was involved with the initial studies by Carmen A. Puliafito at Retinal Shades, Boston. He was working with Massachusetts Institute of Technology. He developed these lasers with being a portable, doesn't require any cooling systems, only a fan can serve the purpose. But initially it was a very shock to the Carmen Puliafito, because infrared, it was infrared, which was invisible light, and 80% of it was absorbed by the choroid. So they said that it is not the laser to be used for the retina initially. But then further research work was done. They found that 80% of the laser which was absorbed by choroid, 50% of that is given back to the retina. So it has become applicable to the retina as well, because 20% is absorbed by the retina, but 80% was absorbed by the retina, but 50% of that was given back to this. And now semiconductor laser is a portable type of laser, doesn't require any water cooling, even air cooling is not required, and it is available into a higher wattage also, so one can serve the purpose. So I just wanted to mention that some new discoveries comes, but fallback, but if they do work on the details, they can come to the conclusion, yes, further improvement can give you a justifiable answer to the disease process.
Yes, sir.
With this
The Pascal
Yes.
काम you can give shots very easily. Does not take much time. एक बार में आपने
Yes,
सवा
एक
सौ
बार में
shots
डाल
एक
के
जगह
आप-
लगाया. Scatter. I couldn't
I
show
think we have
that
got a
because
topic
paucity
also
of
who
time.
it will be covered by some of the speakers on
Okay.
Pascal. Professor Kamaljeet is rightly mentioned, because suppose you have got a 50 laser, it is very difficult. One very do is doing 1500 shots. Simultaneously 500 shots can be given in one go, and thus in a 3 or 4 sittings, 4 shot